Good morning, everybody. It's 11/10/2020. We have just completed our gas cylinders lab. I mean, not lab, but exam. Unit exam is now complete. And now we're going into the next unit, which is medical gas therapy. Now we're going to take that medical gas that we talked about, which is mainly oxygen, right? And we're going to talk about why we give oxygen and what is it doing to the body. Too much of anything can be bad for you. So there are some indications for oxygen. And then once we decide to do something, there are some hazards to watch for. Not really any contraindications to give oxygen now. There's some hazards to look for once you give it, but there's never a reason how you cannot give a person oxygen, okay? No matter what. Don't ever withhold oxygen from somebody, no matter what their condition is, and let them suffer from severe hypoxemia. Remember we said that COPD patients do live to be hypoxic, but that's mildly hypoxic, sometimes a little moderate, but never severe. If they're severe, you must give them life-saving oxygen, okay? And so we're going to learn what we've already learned about how the gas moves from the alveoli into the capillary and how the venous blood comes back from the body to the heart, to the lungs to pick up the oxygen. So we know the movement of the gas. We know why gas moves because of the difference in pressure. The gas, the oxygen inside of the alveoli. We learned that the P big AO2, which is alveolar air equation, the alveolar oxygen tension is about 99 or 100 millimeters of mercury. And that pressure of oxygen should push over into the capillary to return to the heart and to the body as highly oxygenated arterial blood. And it should be around 80 to 100 in the artery, okay? So sometimes it doesn't always go across, and that's because of diseased lungs, right? When we have a greater AA gap or AA gradient, that's an indication of some disease process going on, whether it's COPD, pulmonary edema, fibrosis, ARDS, interstitial lung disease, any kind of many diseases, it could be that problem, okay? And so now that we know all of that, we know how the heart pushes it. We know that the hemoglobin holds on to it, releases it, curves, shift left and right. We've learned all of those dynamics. Now, what about the oxygen itself? We learned that oxygen is colorless, it's tasteless, right? It is not flammable, but it does support combustion. We learned the colors of the O2 cylinders in America and abroad. And we also learned that, is that me? Is that you? Her? Okay. We learned that abroad, what the colors are. And then we also learned that the PIN index safety system is the one we use for the E cylinders, and the ASSS we use for the larger O2 cylinders, right? And we learned different colors for other gases. All right, so this is what we're going to do now. Now we got to look at just oxygen and what it does to the cells in the body. What is oxygen doing? Why do we give it? Why does it help? How does it help? And what happens if we give too much? That is medical gas therapy, okay? And then we're also going to decide or learn, once we know why we give oxygen and what it does to the body, how do we give it to the body? Do I just tell them to go outside and stick their head out the window? No, there's devices that we use from our respiratory toolbook or toolbox, okay? We go everything from small things like a nasal cannula all the way up to a ventilator, or also known as life support, okay? We can start with an everyday nasal cannula, which is a low flow device, right? And go all the way up to a machine, which is a ventilator, also known as a respirator or life support. You'll hear people say he on life support. That means he's on the ventilator, okay? And you are, as the respiratory therapist, the only one that touches the ventilator other than the physician. Nurses don't touch the ventilator. Medical assistants don't touch the ventilator. Physical therapy, nobody manipulates the ventilator or respirator or life support, but the respiratory therapist and the physician. Okay. Now the nurse can hit 100% if the patient is desat and there's a little 100% button on the vent. They can push that to give them 100% while you get there. Okay. Other than that, or the alarms, if it's going off because he's coughing, they can hit the silence alarm and suction your patient for you. But other than that, as far as the rate, the volume, the FiO2, the PEEP, all that kind of stuff is only manipulated by the registered respiratory therapist. Okay. All right. So let's get started with oxygen and why do we give it and what it does to the body. All right, and that is in your module. The PowerPoint is in the module. So I don't have my disk for that one, so I'm gonna pull it up through the module. All right. Gas laws and, oh, no, that's the wrong one. Not gas laws. We are in medical gas therapy. Medical gas therapy 2020 PowerPoint. Download it to my computer. All right, that's loading. I'll bring some more waters tomorrow. Another case. Now, and the lab for this lesson, you'll have to understand, be able to differentiate between low flow devices and high flow devices. Okay, you're gonna be able to have them on the table, and I say, give me a low flow device. You have to be able to pick one up. Show me a high flow device. You have to be able to pick one of those up. All right, put it together. Aerosol face tint, aerosol trach collar, aerosol T-piece, aerosol face mask, right? You have to be able to go and hook those up to show me, okay, how to hook it up. Because now we're getting into the point where we talked about how FiO2 and flow are two different things, okay? They're two different things. And so you can't just say, if you're running out of oxygen, stick your head out the window because you're moving faster. That'll give you more flow, but that doesn't give you any more FiO2 because outside air is 21%, just like inside the car, okay? And so we're gonna learn how to, let me go back, hold on. Share my screen. Let me know if you see the PowerPoint here in a second. See it? See the PowerPoint? Okay. Yeah, so like I said, you're gonna have to be able to put together these high flow devices and show me the low flow devices. Each low flow device has a certain liter flow. Remember we talked about how long the oxygen would last for Mr. Johnson to go to the casino, right? If he's on 2 liters or 3 liters or 6 liters. And when you did your lab yesterday, you were hooked up, you assembled and disassembled the E cylinder and the H cylinder, and you were able to put it on a flow that I desired. I said, put me on 6 liters, put me on 2 liters, whatever. And you're able to do that. And now you know how, if you put them on a certain flow liter, how long it's gonna last depending on how much is in the cylinder, all right? And so now you gotta know which device relates to what low flow, right? You can't put somebody on a nasal cannula on 20 liters per minute, right? It doesn't fit that. There's a certain amount that you can do for each device. And you got to remember that. Like, for example, the simple face mask, when we get to that, is 5 to 8 liters per minute, okay? And so you got to know that. You wouldn't say I put them on a simple face mask for 2 liters. That's not going to work, okay? Because you're going to learn these masks that we have reservoirs, right? The aerosol mask has a little space here, right? Sometimes they have a bag. And if I'm exhaling into a little bit of mass, even though it has holes in it, I'm exhaling what? What am I exhaling? CO2. So if I have that mask on my face and I don't have the leader flow proper, then I risk building up CO2, okay? Because it's collecting in the mask, all right? On the next break, I'll go and get a few of our devices and show them, and I'll show them here as well on the PowerPoint. So let's go. Let's get on the first little bit. It's 9:38. All right. So now we're at the nitty gritty. This is what you give. Oxygen is a drug. It has to have a prescription. You can't get addicted, okay? People don't want to ever get off. So you have to get them on, solve the problem, and wean them off as quick as you can, because they will get addicted to the machine. They'll get addicted to the actual oxygen itself. All right, medical gas therapy. Why do we give it? There are three main reasons why we give oxygen. Number one, to treat hypoxemia. To treat hypoxemia is the number one reason why we give oxygen. It's most effective when treating a low P little AO2 due to a low P big AO2. So what they're saying is if my arterial, which is little a, oxygen is low, it's probably because my alveolar oxygen tension was low, right? So if that's low, if I put some oxygen in his nose, he's going to breathe it in and go into his alveoli, thus making the alveolar oxygen pressure higher, which will push into the alveolar greater, okay? So, and that's basically what's happening. You're breathing in some FiO2, which goes into the alveoli, right? And then the gas exchange happens, and it improves that gas exchange because you're giving supplemental oxygen. Regular healthy lungs can breathe the outside oxygen in and be enough, okay? We have regular oxygen rates at room air. We're not designed to be breathing extra oxygen, okay? But when there's a disease process or there's some type of pneumonia or some type of sickness that's going on, and the transfer of oxygen into the capillary has decreased, then we can give a little supplemental oxygen, which is give them a little higher FiO2 and to help overcome that issue, okay? So if they're desatting because they have fluid in their lungs and pneumonia all in their lungs, it's harder for the gas to go through that secretions, right? The oxygen can't get through a loogie to get into the capillary. So what we do is we can put more oxygen in so that more can get through. Once we fix the problem, like the pneumonia or whatever's causing it, then we can back off the oxygen, okay? All right, so the main reason is to treat hypoxemia, may be used in treating anemic hypoxia and circulatory hypoxia, right? It's most effective in hypoxemic hypoxia. Hypoxemic hypoxia is simply what? Hypoxemic hypoxia is simply what? There you go. A low PaO2. That's the number one. You got hypoxemic hypoxia, which is just another word for saying, which is simply saying you have a low P little AO2. That's why I said number one, most effective when treating a low PaO2 due to a low P big AO2. That's called hypoxemic hypoxia. All right, but then anemic hypoxia was because of the hemoglobin was low, misfunctioning, or carbon monoxide poisoning, okay? Because in carbon monoxide poisoning, the hemoglobin is the problem. He won't pick up oxygen, right? Because there's so much carbon monoxide around, he won't pick it up. He's just looking at it crazy because he won't pick it up. So that's a hemoglobin problem. So if it's hemoglobin related, it's called anemic, all right? Also, circulatory hypoxia. If the perfusion is low, your blood is not circulating well, right? So if it's not circulating well, there's just a little bit of blood down there. And if there's a little bit of blood, it's not going to be a high FiO2, right? The oxygenation is going to be low. And so we can breathe in extra oxygen so that the little blood that does reach the tissues is fully saturated, okay? Now, remember that hypoxemia is determined by a P little AO2 less than 80 millimeters of mercury. when hemoglobin is normal. Please don't name one of y'all's children millimeters of mercury. I don't know. I don't put it past the society today. Mercury, because they was in respiratory when they got pregnant. So a low P little a O2 less than 80, that's hypoxia, right? Anything less than 80 is starting to be mild hypoxemia, okay? Also, a total O2 content less than 17, right? Was really, well, at 17 or less. It's starting to be mild hypoxemia, right? Number 2, to decrease the work of breathing. To decrease the work of breathing. We said once the body sees that we are hypoxic, it will start to breathe harder and make the heart pump harder. And that is done by the peripheral chemoreceptors. Peripheral PO2. Peripheral PO2. So hypoxemia stimulates those peripheral chemoreceptors, causing you to breathe deeper and also making your heart beat a little harder. Okay? Now, which ones only focus on breathing deeper? Which one of the peripheral chemoreceptors focuses on the breathing part? One of the peripheral chemoreceptors focus only just breathing, and another one is breathing and heart. You got 2 peripheral chemoreceptors. Carotid bodies, the carotid bodies part of the peripheral chemoreceptors up in the common carotid bifurcations of the common carotids, right? When they sense PO2 being low or hypoxemia, right, they'll make you breathe harder, okay? But if you have, what's the other one? Aortic. The aortic bodies are the peripheral chemoreceptors that sit right on the aorta. And when they sense it being a little low, they make the heart beat a little faster, okay? So you got peripheral chemoreceptors that respond to PaO2 being low, which is hypoxemia. That's why the COPDer lives only by this one, okay? That's why he has to be hypoxic. If he's not hypoxic, he's not going to breathe. He lives to be what? Mildly hypoxic. And so when you make his hypoxia go away, then his body says, okay, I have no reason to breathe anymore, okay? He starts to breathe slower and slower and slower. That's why it's called oxygen-induced hypoventilation. Oxygen-induced hypoventilation, because he starts to breathe slower and slower, because you ain't giving him a reason to breathe. You ain't, see, hypoxemia is doing him like this all day. Hey, wake up, breathe, because I'm hypoxic, right? But if you take me away, then who's stimulating them? Nobody, okay? Nobody's there to stimulate them, okay? So you got to keep me on deck, but mildly. Not having blue in the face. Oh, you got COPD. I ain't giving you no oxygen. Can't do that. Okay. Can't do that. All right. Number 3, or that's number 3 of number 2. A patient with an increased respiratory rate to maintain an adequate PaO2 will only be able to do that for a short time. So when you become hypoxic, your body will start to breathe faster, right? Because of the peripheral chemoreceptor. It's going to say, hey, you need, come on now. This ain't enough. This ain't it. Wake up. Right? But then you start huffing and puffing. You can only do that for so long. You will get tired and pass out. Okay, you can only do that for so long. So we have to notice that increased work of breathing and introduce some supplemental oxygen. And the body say, oh, okay, appreciate it. Right? And he'll calm on back down. Okay? Person will come on back down. Heart rate will go down a little bit because they're not hypoxic. When they become hypoxic, their heart rate shoots up and their rate increases, right? Because the body's trying to get that oxygen to the it needs it every moment of your life. You gotta have it. I don't care nothing about your disease. I need it. And if you don't have it, I'm gonna do what it takes. Even if I have to put you out, would pass you out, put you in your body will put yourself in a coma to handle its life. It wants to live. It's almost like it's got a life of its own. Okay? It wants to live no matter if you do or not. So if you was to sit here and hold your breath, how long you think your body gonna let you do that? Not long. Right? Some people can do it longer than others, but eventually everybody's going to pass out, okay? And the body going to knock you out and start breathing. Best believe once you pass out, you're going to be breathing normal because he needs his oxygen. No matter what you going through at home, he don't care. He needs to breathe, okay? All right, not indefinitely because of diaphragm fatigue and the O2 debt created. So that's what he's saying. You can only do it for so long. You can only try to make up that PaO2 with increased breathing for so long, right? Then you're going to fall out. So we got to give them oxygen. So that's the second reason why we give oxygen, to decrease the work of breathing. The third reason we give oxygen is to decrease the myocardial work. It's hypoxia increases the heart rate and strength of contraction, because the carotid body on the peripheral chemoreceptor says, hey, we're a little low. You need to pump harder, right? Don't you feel the music pumping hard like? Come on, finish it. Come on, you know it. Don't you feel the music pumping hard like? I wish you would. So y'all know Salt and Pepper Push It? Y'all remember that song? You don't remember that? Damn, y'all young. That's what. I'm 42. I'm 42.
You look 42, so we can, yeah. So we can kill just a little bit old.
Oh, okay.
Yeah. Look, at least me.
Well, I'm sorry. I thought that was gonna roll over right, but I guess not. So that's what it's saying. I need you to pump a little harder, okay? And so we don't want to pump a little harder for too long, because that's going to cause a problem, okay? That could cause arrhythmias, the heart could get fatigued, all of that, right? So we need to give some oxygen so the heart can chill back down, okay? So decrease the myocardial work is the third reason we give oxygen. So three main reasons: to treat hypoxemia, to decrease the work of breathing, and to decrease the work of the heart. All right. It says compensates for decrease. Yeah. Hypoxemia increases the heart rate, which will compensate for that decreased PaO2, right? You'll start pumping harder, trying to get more blood to the body in hopes to bring more oxygen. But you can only do that for so long. So oxygen therapy will increase that PaO2, thus decreasing the need for the heart to work so hard. Okay. All right. Now, those were the reasons we give it. Now you have to, once you decide to give it, you have to watch for a few things. And that's called the hazards of oxygen therapy. Yes, there are some things that oxygen can do to kill you or harm your body. Too much of anything is not good for you. Even water. You can drink too much water. Okay? Oxygen toxicities, number one. The number one hazard of O2 therapy is oxygen toxicity. Now, when I say number one, I'm not saying the worst one or there is certain order. I'm just giving them to you. I think it's 4 of them. Number one, oxygen toxicity. It's caused by two things: FiO2s and time. Okay? FiO2 and time. So what they're saying is, if you have a FiO2 greater than 50% for longer than 24 hours, you could possibly cause oxygen toxicity. It can start to become toxic. That's why we like to keep that FiO2 below 50% as much as possible. So most of your ventilator patients will be on 40% or less, unless they're just so sick we have to bump them up. But we want to get down as fast as possible because they can become toxic. Okay? Oxygen toxicity is needs to be two things: FiO2 and time. FiO2 greater than 50% for longer than 24 hours. That can cause oxygen toxicity. How does it manifest? How will I know if they're becoming toxic? Well, it can cause pulmonary edema and consolidation. It can cause alveolar cell degeneration and dysfunction. It can cause atelectasis and also cause hyaline membrane formation. Now, what this is as the alveoli stretch, right, or become damaged, they collapse. And those damaged cells collect in the airways and further affect the way that gas can exchange, okay? As those alveoli start to die, the alveoli start to break down, they are dead cells. They become dead cells, and those dead cells can get in the way of those respiratory bronchioles, and the air can't get in and out anymore. And that further makes you hard to breathe. That's called hyaline membrane formation, because once they die and start getting in the way of the airway, those little cells are then called hyaline membranes. Hyaline membranes. That's the manifestation of oxygen toxicity. What will be some of the symptoms? Because you can't see that. I can't say, oh yeah, you got some alveolar cell degeneration ain't going on in there. You can't diagnose that by listening to it or telling them. You can't, you know what I'm saying? You got to really know it or see it through an x-ray or something, CT. Okay? But the symptoms you can find out. Retrosternal pain, that's pain where? Retrosternal pain will be what? Where? Where in your chest? Where's up in here? Huh? On the sternum? No. Not exactly. Retrosternal means what? Not around. What's retro mean? Behind. Behind the sternum. You have pain behind the sternum. That's retrosternal pain. That's a key sign of oxygen toxicity. That's some of those terminology from 210A questions. Retrosternal pain, cough, like a real dry cough. Dyspnea, which means shortness of breath. When somebody says they're short of breath, you say they're experiencing dyspnea. Paresthesia. Paresthesia. Those are the 4 symptoms of oxygen toxicity. It's kind of like tingling in the fingers and tingling in the hands and stuff like that. Paresthesia. So the first hazard is oxygen toxicity, which must be 2 things, high FiO2 and time, right? FiO2 is greater than 50%, and they say sometimes even lower, but we're going to go with 50% for more than 24 hours. Okay, more than, not 24 hours, but more than 24 hours. Okay, because sometimes you'll have a patient that come in, you got to give them 100% all day to overcome an issue, okay? Less than 24 hours, nothing can hurt nobody. But after 24 hours is when this stuff starts happening, okay? So FiO2 is greater than 50% for more than 24 hours. You see how it manifests, and some of the symptoms are retrosternal pain. They come out with a cough out of nowhere, short of breath. Even though you're giving them oxygen, now they're becoming short of breath again. That might be because of the oxygen and paresthesia.
So I have a question.
Mm-hmm.
So what if a patient comes in and they HYPOXI and we give them an oxygen and it doesn't fix the problem right away, and we know if we continue, it's called oxygen toxicity.
Depending on how much you're giving them. Yeah. 50% or greater.
So if we reach the point where it could cause it, do we cut it off, wait a while, and cut it back on? No,
you would just have to see if they're not responding, you're gonna go on up. So you're gonna be going on up the ladder. If I give them a little oxygen, their sats are still low, and then going on a little longer, I put them up to, they're on 100% mass, and the oxygen is still low. Then it's now time to start thinking about intubating, putting the tube down his throat, and pop them lungs open. Evidently, something's going on with his alveoli, closed a lot of places, and he just can't do it. And so we have to breathe for them. Either put a little mask on their face and push air like CPAP, a BiPAP or CPAP machine, or the ultimate thing will be to put them to sleep and intubate them. You won't just say, you sat in 80%, we're going to give you 24 hours, and then we'll come back, right? We can't do that. You got to get that sat back up. So you might be intubating in 5 minutes, depending on your patient. If he's deteriorating quickly, intubate him. You don't wait. So you'll never get to the point where we've been given 50%, it's 24 hours, now we got to make a decision, right? You would already be intubating them, okay? Now, when they're on a vent, if they're in ICU and they're sick, you might have them on 50, 60% for days, just what you got to do. But you'll be breathing for them and watching that very closely, okay? But you got your toolbox, start low and have to go all the way up to the vent, you have to go all the way to the vent, right? You have to make that decision quickly, okay? Can't let them wait. Some of the symptoms, again, like the eyes, they can have a little field vision loss, nearsightedness, cataract formation, a little bleeding, fibrosis. They can have a seizure, muscle twitching, right? And then respiratory, jerky breathing, kind of like panicky breathing a little bit, not hard, but kind of like shaky. Irritation, coughing, pain, shortness of breath, tracheobronchitis, acute respiratory distress syndrome. All these things can happen if you're giving them 2 months out. You just got Mr. Johnson on 50%. He watching the game, and he been on there for 2-3 days. That ain't gonna work. You can't do that. You got to try to get that oxygen back down. Okay, he'll start to have these symptoms. All right, the second hazard of oxygen therapy is absorption atelectasis. Absorption atelectasis, and this is also 2 key things, 2 necessary components. All right, so what happens is normally nitrogen fills 78% of the space in the alveoli, right? Because what's the percent of nitrogen in the atmosphere? 78%. 78%, right? 78% of the atmosphere is nitrogen. 21% is oxygen, right? And it exerts a pressure, okay? It exerts a pressure. What is the pressure of nitrogen inside the lungs? Work it out and tell me what the pressure inside of nitrogen, inside the lungs and alveoli. How much pressure does nitrogen exert? How much pressure does nitrogen exert in the atmosphere? Don't forget about Dalton. You got to use Dalton's law to figure it out. I think it's close. More than that. Close. It's more than that. I think it's 596, something like that. I don't think it's 506. 592. 592. Okay. All right. So nitrogen is 78% of the atmosphere. That is 0.78 times what? 760 equals what? 592.8 millimeters of mercury.
Not restricted to 13? I mean, 47?
Not yet. No, this is not the oxygen part. Okay, this is not the oxygen. We just going by what nitrogen. When you pull in the nitrogen, this is what it exerts. Okay, it exerts 592. So that's nitrogen. 592 millimeters of mercury. How much does we say oxygen exerts in there once we get rid of the water pressure and the CO2? Alveolar equation. How much oxygen in the alveoli? It's 159, but I'm saying after you subtract the CO2 and the water pressure from oxygen, what's left of oxygen in the alveoli? 99, or just 99. All right, so then O2 is about 99 millimeters of mercury, right? So which one is the most? Nitrogen. So that's nitrogen's job. Remember I told you we're going to find out why nitrogen so much and oxygen so little if we leave oxygen to live, right? Well, nitrogen is what keeps the alveoli open at all times, okay? Nitrogen keeps alveoli. So the nitrogen keeps alveolus open. Okay, it's the strong force. Nitrogen is doing this on the walls of the alveoli. Okay, nitrogen is holding those walls open so that oxygen can come in and do what it does. Exchange going on. CO2 and oxygen can be exchanged, and nitrogen is there simply to hold it open. Okay, now what happens is in absorption atelectasis. What happens during absorption atelectasis is we take in high levels of oxygen, right? So O2, what did it say? Greater than 70%? Yeah. O2 that's greater than 70%, right? Going in. for an obstruction. So say there's a little airway obstruction, right? Which will be this right here. If there's a little airway obstruction in there for something that's kind of blocking the alveoli, but at the same time, we got great numbers of great amounts of oxygen pouring in, right? We have high levels of FiO2, usually greater than 70%, accompanied with an obstruction, all right? This is what happens. This will slowly disappear. The nitrogen is washed out, all right? At this point, nitrogen is washed out. So if nitrogen is washed out, what happens to the alveoli? It closes, which results in alveolar collapse. Okay? That's called absorption atelectasis, because atelectasis is anytime you have an alveoli that's closed. Okay? Atelectasis, guys, is a closed alveoli. Okay? If it's closed, little pockets of alveoli that start closing up is called atelectasis. Okay? That's atelectasis. And sometimes if you're just laying in the bed for a long time, your body will start to close little parts of the lungs because it's not in use. That's atelectasis. Somebody who has high sedation after a surgery, right? They're going to come out and not take deep breaths. If you're not taking deep breaths, you start to have atelectasis, which is it's okay. It can be fixed unless you don't fix it in time, right? So in that case, we'll put that little this in their face. How many have you seen this in somebody's room? Seen this? Seen this right here in somebody's room? This is an incentive spirometer. Incentive spirometer. What they do is they don't blow in, they inhale and let this bellows goes up, and it matches it. You set this to where they should be based on their age, gender, and height. So if they say, Mr. Johnson, you need to be at 2,000, and when he inhales, he only going to 50, he's got some atelectasis, and he has to keep practicing over a couple of days. He'll eventually get to where he should be, because those deep inhalations will pop those lungs back open, okay? And so we'll get to this later when we get to J, all right? But that's what atelectasis is, little pockets of closed alveoli, all right? So what absorption atelectasis is saying, when there's an obstruction and you have high levels of FiO2, the O2 will continue to be absorbed, but the nitrogen can't, okay? Nitrogen can't get in there because of the obstruction, but the oxygen can get in there. And what happens is you wash the nitrogen out. That's called nitrogen washout. When the nitrogen is gone, which is holding the alveoli open, when he's gone, the alveoli just closes because of that, okay? So that's absorption atelectasis, all right? So that's the second hazard of O2 therapy. Absorption atelectasis. So let's look at the PowerPoint so you can fill out your paper. All right, absorption atelectasis. Normally, nitrogen fills 78% of the space in the alveoli. With high FiO2s, usually 70% and greater, the nitrogen is washed out. If the alveoli is obstructed, the O2 will continue to be absorbed from the alveoli into the blood. But then the alveoli falls below critical volume and it collapses. Okay? The volume at which the alveoli needs to stay open is called the critical volume. Just like the temperature in which oxygen needs to stay a liquid is called critical temperature. Same thing with alveoli. There's a volume in the alveoli that it has, once it's below that, it closes. Now, I don't know what that number is, and you don't have to know it either. Just know if it collapses, it's because it fell below that number, okay? Critical volume of the alveoli is simply enough volume that has to be there in order. Can I help you? What is what? Orientation is up at the front. All right. So absorption atelectasis is because you're going to continue to absorb high levels of FiO2 accompanied with an alveolar obstruction will then wash out all of the nitrogen and collapse, right? So what are the two necessary components? High FiO2s above 70% or more, and what? Obstruction, both of those. So when you see a test question that says all of these are needed for absorption atelectasis, and they just say FiO2 is greater than 70%, and they don't say anything about an obstruction, don't pick that one. It has to be both. FiO2s above 70% and an obstruction. Both of those are needed. All right, now I also may say nitrogen is washed out. Yes, that's true, right? Oxygen is continuing to be absorbed. Yes, that's true, right? So it might be multiple. You know how you have those multiples. So know everything about absorption atelectasis. Any questions on absorption atelectasis? You understand what's going on? Okay. The next one, oxygen-induced hypoventilation. Now, this is what we've been talking about. This is our who? Oxygen-induced hypoventilation. Somebody you're giving oxygen to and causing them to stop breathing. Who is this? COPD. COPD patients. Because of the hypoxic drive, you're right, Ms. Rose. Because of the hypoxic drive, you washed it out, right? And so that's what it says. Hypoxic drive at the top of the screen causes is one of the byproducts of oxygen-induced hypoventilation. So let's look at number one. Chronically hypercapic patients or hypercarbic patients. These are patients with what? High CO2s. And who's got high CO2s all the time? COPDers. Okay, COPDers. High CO2 with a relatively normal pH because they're fully compensated. Your COPD patients are usually fully compensated respiratory acidosis. The CO2 is always high. The bicarbonate has come up to kind of buffer it out, and the pH is back into normal range, but leaning acid. Okay? Fully compensated respiratory acidosis for your COPD patients. They're always going to have a high CO2, and they're always going to have mild hypoxemia. Okay? So the patient no longer responds to the central chemoreceptor stimulation to breathe because their CO2 is always high. So central chemoreceptor is do what? How does the central chemoreceptor respond? What is it? What is that all about? The central chemoreceptors. CO2 in the what? Ms. Wood? The CO2 in the what? No, not necessarily low. The central chemoreceptors respond to CO2 levels in the what? What part of the body? I said the central chemoreceptors. You got central chemoreceptors and peripheral chemoreceptors. The peripheral chemoreceptors respond to hypoxemia, and the central chemoreceptors respond to CO2. But that CO2 in the what? Not the lungs. Huh? CO2 in the what? We already learned this. Medium right there on the table. Oh. No. You're welcome. Mr. Rivers?
For some reason, I just remember CO2. I don't know why.
All right, well, look it up. I'm going to pause this and y'all look it up. The cerebral spinal fluid. The central chemoreceptors respond to carbon dioxide in the cerebral spinal fluid. It flows in and out freely, right? And so when the CO2 levels in the cerebral spinal fluid become elevated, then the central chemoreceptors make the body breathe more. Hey, you need to breathe, blow some of this off, bro, right? But since the COPD patient's CO2 is always high, then the central chemoreceptors don't know how to respond. They don't work anymore because it's always high. okay? It's chronically high. So now they have smoked that one away, and all they have left is the peripheral chemoreceptor. And since they live to be hypoxic, if you give them too much oxygen, you have knocked out the hypoxia, okay? And so now they start to breathe slower and slower until they go into respiratory failure, all right? So oxygen-induced hypoventilation is a hazard of O2 therapy. That's one of the hazards. It says chronically hypercarbic, which means high CO2 patients. The patient no longer responds to the central chemoreceptor stimulation to breathe because the CO2 is always high. It doesn't know how to respond. It doesn't know how to respond, okay? It responds to stimulation of the peripheral chemoreceptors in the carotid bodies to breathe. Stimulated mainly at P-little-a-O2s less than 60. I'm gonna put 80 right there, but it's less than 80. And then administration of too much oxygen can decrease ventilation. Administration of too much oxygen will decrease their ventilation because you have knocked out their reason to breathe, okay? If they are hypoxic, Ms. Woods, if they're hypoxic and that's why they're breathing, you take the hypoxia away from them, what does he do? Hypoventilate, okay? Not immediately, but he'll start to slow up, okay? So if you got granddaddy in the back room watching the game in his newspaper and all that, he on an oxygen machine, right? And his oxygen sat is 91, 89. That's okay for him because he needs to be hypoxic, okay? He needs to be. But if you go back there because you're a new therapist and you see his little sat on your little finger pro, oh, granddaddy, you 89%, let me bump you up a little bit. And you turn his oxygen flow up on his machine, and then he's sat in 100%. Oh, yeah, you did. Oh, well, thank you, baby, right? He's going to keep on watching the game, but 2-3 hours later, you go in there, he's asleep and can't be roused because you have knocked out his hypoxic drive, and his CO2 has crept up because he's breathing lower. And now his CO2 is building up so much, he goes into respiratory failure. Okay, that's what respiratory failure is, not being able to get the CO2 off.
It gets. How do you know when to increase and when not?
What you mean?
How do you know if they're supposed to be mildly hypoxic? If they're COPD,
if they're a smoker, if you know that they're COPD, then you want them to be mildly hypoxic.
So what? For instance, some people lie about smoking.
Well, then that's on them. I mean, you can only do what you know. Okay. But you know, if they come to the remember what I said, no amount of oxygen affects anybody in less than what? You can give any amount of oxygen less than this amount of time, 24 hours. So if you don't know what his history is, he ain't gonna be in ER for 24 hours, first of all. Okay. And so you're gonna have to get a history from the person or whatever within them 24 hours. Right? He ain't gonna be able to lie that long. But a lot of times they say they don't smoke, they just quit yesterday type of thing, they COPD. Okay. Yeah, I used to smoke, I've been quit for 5 years. But how long did you smoke? 30 years. He still got COPD. Once you got it, you got it. You don't care if you quit for 20 years, you still got COPD. The damage is done. Lung damage is irreversible. Once it's done, it's done. Okay? Once it's done, it's done. All right. So, oxygen-induced hypoventilation. You knock all of the nitrogen out. And the other one, which is absolute absorption ATELECTASIS. You knock the nitrogen out, right? And their alveoli collapse. Now, on this one, oxygen-induced hypoventilation is when you give a COPDer too much oxygen, right? You have knocked out their hypoxic drive to lead. If I am hypoxic, look at me. I'm hypoxia, okay? And you are the patient. I'm like this all day, every day, because I'm here. That's making you breathe, right? If I leave, who's going to stimulate you? Nobody. Who's going to stimulate you to breathe? Nobody. So you're going to stop what? Breathing. That's as simple as I can put it. Okay? Any questions on that part? You understand how this happens? If you don't, ask me now. It's not a rush. If you don't understand, ask me. What part do you don't understand? Okay. But you understand this concept about oxygen-induced hypoventilation. Okay, good. I mean, it's not bad if you don't know. Just let me know. Not a big deal. All right. So, hypoxemia is when their oxygen is less than 80. Right? Anything less than 80 starts to become mildly hypoxic. Okay, mildly hypoxic. Told you I'm going to change this 60 to 80. It used to be 60. Now it's 80. Say 80. Less than 80 is mildly hypoxic. Okay. Matter of fact, we're going to change it right now. There ain't no question. 80. All right. All right. Administration of too much O2 can decrease a person's ventilation, resulting in an increased CO2. Because if you don't breathe, if you don't ventilate, you're going to start to build up more what? CO2, and they're going to get so high that's going to be an acidosis, such a high acidosis that they're going to pass out and possibly die. Now, the reason why they don't just die right there like that, the reason why they die is because they stopped breathing and nobody came to check on them. That's the type of thing. You know, you don't check on granddaddy for about 2 days. He in the back. You know how that people have a family member in the back somewhere, and you done turned his little oxygen up, and you didn't check on him for the rest of the day, and then tomorrow morning you go with his breakfast and he's dead. Okay, so you have to be careful with that, and you have to know your patient's history. Because if you know they have COPD, you have to start be thinking how you're going to treat this patient, okay? Not like you would treat somebody who doesn't have COPD, all right? You can't force a good ABG on a COPD. Their COPD, ABG is always going to be completely compensated respiratory acidosis, always, okay? Always, with mild what? Hypoxemia. All right, this is just some pictures of some a blue bloater and a pink puffer. This is how they look. Your chronic bronchitis patients usually look a little bit bluish, okay, all the time. Chronic productive cough, bro. You don't have to know. I just threw this picture in. And your pink puffer is the one that has emphysema, usually frail, okay, frail and look kind of like that. Now, the next, number 4, the fourth hazard of O2 toxicity, of O2 therapy, retrolineal fibroplasia, RLF, or retinopathy of prematurity, ROP. This is when you cause blindness in the infant. Too much oxygen can cause your infant to go blind, okay? So what happens is high PaO2 causes vasoconstriction in the retina, which leads to necrosis of the blood vessels, okay? The retina, the vessels in the retina become constricted, okay? They come closed. And if you close off a vessel, you have ischemia to that person, to that place, right? Remember we said ischemia is lack of blood to an area. Lack of blood to an area is ischemia, right? It's suffering from ischemia. Then if you don't get that blood there, it leads to that death, okay? It leads to death. If those blood vessels are not flowing, they die. All right, they become necrotic, which means death. In the presence of that dead vessels, new vessels spring up out of nowhere, right? But they tend to hemorrhage because they're made so fast, right? It's amazing how once those blood vessels are constricted and they become necrotic, the new blood vessels will try to move around the deadness, right? They'll try to form up. It's amazing. They form up and they move, but they form up so fast that they burst. They're usually really, really weak, and they burst, causing blood hemorrhage. That's what hemorrhage is, right? Causing blood to be in the retina and scars the retina, which causes blindness. Once that retina is scarred, it causes blindness. All of those vessels. Okay. Infants up to 1 month are at risk. Up to a month. After about a month, you're not at this risk anymore. So it's usually your premature infants and your infants that have to go on oxygen for some reason. If you have a sick infant and they're in a hospital and they're on oxygen, if you're the therapist, you got to make sure his little PaO2 is not above 80. So you'll be sticking for an ABG, but for a baby, you stick them in the heel. It's called a capillary heel stick. You squeeze his little leg and his little foot, it get real red, and you stick them in the heel. That's arterial blood, and you'll run it. If your PaO2 is greater than 100, you need to cut their oxygen down. Because if you don't, you risk RLF or ROP. Okay?
What are we sticking for adults?
ABGs are in the artery, either radial or brachial. You'll learn it in 220. All right, any questions on RLF or ROP? RLF and ROP causes too much oxygen greater than what? A PaO2 greater than what? 80 millimeters of mercury, not 80% on the wall. 80 millimeters of mercury. We're talking about PaO2. Okay, when you get an ABG and his PaO2 is greater than 80, you run the risk of blinding him because of RLF or ROP. Okay. All right. Guidelines for oxygen administration. We'll take a 10-minute break here. It's 10:25. Come back at 10:35. 10:35, we're going to do the general guidelines of O2 therapy. In fact, don't take a break here. I'm going to do the general guidelines of oxygen therapy, and then we're going to stop because I don't want to go into low flow systems and then stop you. I need to give you low flow and high flow on the same day. So we'll be doing low flow systems and high flow systems starting in the morning. This is when we're getting ready to talk about who qualifies for low flow, who qualifies for high flow, and how do I know that, okay? How do I make that distinction? So here's a little general guidelines today as I close for the day. Good job on the exam. Everybody, almost everybody had an A, okay? So good bounce back for everybody, okay? Now, general guidelines for O2, it says oxygen concentrations less than 40% rarely ever cause oxygen toxicity, right? Under 40% rarely ever cause oxygen toxicity. 100% has not been shown to cause toxicity if you lose it less than what? 24 hours. C says 100% oxygen is not contraindicated for brief periods of emergency. I don't care if he got COPD or COPD. If he got the biggest, worst COPD, and if he's in emergency, you give him 100%. Okay, if he's sat in 30 or his PaO2 is 65, or I mean not 65, but 45 or 25, give him oxygen. They don't ever hold back oxygen because, oh, he got COPD, but see, he's sitting here blue in the face, but I ain't gonna give you no oxygen. Right? Don't ever do that. Okay? Don't ever do that, because this is what Shapiro says. Shapiro was one of the first texts. You know how you got this book, Egan's? That's what we used to have Shapiro, right? But when I was in school, it was Shapiro. Now, then was Weicker, now it's Egan's, okay? Shapiro says he's a respiratory therapist who wrote that book. He said, to allow a patient to be exposed to dangerous levels of hypoxia for fear of oxygen toxicity is intolerable. You will be fired. All right? Never let somebody, because if they go into hypoxic respiratory failure, they're going to die. And they said, why they die? Because he was hypoxic for too long. Well, why in the world was he hypoxic and got all this oxygen in here? How was that? Oh, well, the therapist said he had COPD, so we ain't give him none. You're going to be under the jail, okay? You're going to lose your license, and it's a done deal. Don't ever do that, okay? Don't ever be that scared. You got to just make a decision, okay? If his PaO2 is 40 or 20, give him whatever he needs to get it up to mildly hypoxic, okay? All right. E, that's what I said for now. E, use minimal oxygen concentrations to achieve a state of no hypoxemia, right? Use minimal amounts, right? If you were trying to buy a car, and you got 50,000 in your pocket, are you gonna go right to them and say, I got 50,000, I need a car? You're not gonna do that. You will if you have to, but you're gonna start low as you can, right? You got 50,000 in your pocket, say, I got 5,000, bro. What can you do for me? And they go, well, I can't do 5. Can you say, oh, I'll do 7, right? You use little oxygen that you need to achieve getting that car. You're going to use as little oxygen or cash that you can to get that car, okay? Well, if you doing oxygen, you want to use as minimal levels of oxygen as you can to achieve a state of what? No hypoxia. We ain't talking about the field. We just talking about general. No hypoxemia, right? So if 2 liters is enough to get him out of hypoxemia, cool, we're gonna use 2. If it takes 4, use 4. If it takes a ventilator, use the ventilator. But don't go in the room and he's sitting a little low and you put him on, all right, go to sleep, I'm putting this tube down your throat and breathe for you. Don't jump right into that. Use as little as you can to achieve, because it can cause so many hazards, okay? And then monitor your patients very, very close. Now, before you leave, I'm going to show you this one little thing, this little clip, like a 2-minute clip, and then I'm going to be done. All right. Show this clip. I think it's in the module. If it ain't, then don't worry about it. I could have swore I put it in here, though. Study pitch. Okay. Oh man, I thought I did. Where is that at? I had it in the thing. I don't know what happened to it. Oh, come on. Oh, yeah. Here it is. All right, so can y'all see my screen? Y'all see YouTube up? Okay, let me
Did you need something, sir?
I am having trouble breathing.
Well, let's... Did you need something, sir?
blur it now. Okay. Okay, so I'm gonna stop the recording because I don't want to hear about it. This is somebody else's YouTube thing. If I play it during my...
So what you do is the doctor disagree with you.
What you mean disagree? About what?
With you saying give it to him to the sex club, the doctor say, well, now.
Well, he's not gonna say no. If he's blue in the face, he's not gonna say no. No doctor's gonna say no. If they are, they on drugs. Something wrong with them.
I mean,
they're not gonna do that. They're not gonna do that. If you have a time where the doctor is saying something crazy, It's like just like we did in RT 210A. When you don't agree with something, you let the supervisor know. Let the supervisor know. Say, look, this patient is blue in the face, and Dr. Jones is saying don't give him no oxygen. He don't want him to have none, and he's satting 50%, and he's dying. You go to the supervisor. Okay? The doctor is not the head honcho of the hospital. You go to your supervisor, and they can go from there. All right? Just like if a doctor say this patient ain't getting no better, we're gonna go and take the vent off of him. And you don't, if the family ain't said that, he can't make that decision, or she can't make that decision. Okay, that's got to be a family thing. You need to let somebody know if that's what he or she is planning on doing. Okay, but we're all in this together. So tomorrow, guys, we're going to go over low flow systems and high flow systems. I'll have them in the room where I can show them, as well as the PowerPoint is going to show them. You don't have homework tonight because everybody that took the test, you have your attendance for the day. So don't worry about homework for tonight. But tonight I will want you to get into the reading on the syllabus for this section. Okay, look at the reading chapters for this section. Also, if you want to go on and look at that PowerPoint, go ahead and keep looking at it. See if you can kind of understand it before I go over it, so you'll be a little bit more ahead of the game on tomorrow. Okay, stay ahead. Now we're into oxygen therapy. This is a little more difficult than the last test. Don't forget those hazards. Go over those hazards so you know them by heart. So when I ask you tomorrow, or I gave you a pop quiz on the hazards of O2 toxicity, you'll know which one is which. All right, don't just wait for me tomorrow. Study tonight. Stay above it. If you're passing right now, I showed you your grades, keep it up. That grade that I show you is anticipating that you get a 75 on your following grades. That 75 is already factored in. So if you get a lower grade than a 75, that's going to drop it. If you get a 75 on the next test, it's going to stay exactly the same. Okay, because it's already factored in that you're going to get, it's expecting you to get at least passing on all of the tests. Okay, so if you got an 85 right now, you score a 75 on the next test, you got an 85 still. Okay, because it already anticipates you getting that 75. Okay, the grade that I show you, this is the grades that you have, not necessarily the one in Canvas, because a lot of times those homework assignments for no points or 10 point, all that kind of stuff, throws it off. So your grade that I give you on that spreadsheet is your grade. All right. See you tomorrow. Be careful. Study tonight, and I'll see you tomorrow.